We are live now, doctor.
Okay. Thank you. So welcome everyone to this webinar, which is focusing especially on aesthetics, and it's organized by the Young Ophthalmology Society of India. This is the current team of YOSI for the past 2 years, and with Dr. Devakant as the president. This is the vibrant team of executive committee that is there. We have good representation from oculoplastics, as you can see, Dr. Ayushi, Dr. Rolika, Dr. Puneet, and they have actually been spearheading all of the programs for oculoplastics that have been happening with YOSI so far. And these are all the activities that YOSI conducts. This particular is not for this. This is actually just prior to the YOSICon, which is the main activity of YOSI. YOSI does have a core oculoplastic focus group also, led by Dr. Puneet Jain, and the coordination is done by Dr. Nupur, and we have Dr. Shruti as well. So the reason we are conducting this webinar is because we have certain workshops, especially an aesthetics workshop, which we are conducting at the YOSICon in Delhi on July 11th. So before that, we felt that instead of having complete didactic lectures at the workshop, we felt it would be worthwhile having some introductory lectures from eminent faculty who may not be able to attend YOSICon. So we have their expertise for us, for everybody to refer to all across the world, because it's an international conference and many people are interested in attending and listening to this entire program as well. So the Dr. Puneet, again based in Delhi, Dr. Nupur in Noida, and Dr. Rolika in Jaipur, Dr. Shruti in Kochi, and I am based in Delhi again. And my co-moderator, Dr. Ayushi, she is currently pursuing her fellowship, her second fellowship, I should say, in South Australia under Dr. Dinesh Selva, again very prestigious, and she will be conducting this webinar with me. We have our esteemed panel, Dr. Aditi Grewal. She is based in Chandigarh, and she is an oculoplastic surgeon at Grewal Eye Institute in Chandigarh. And with us, we have Dr. Sumer Doctor, and he is an oculoplastic surgeon based in Mumbai at Dr. Eye Institute. And he is again one of the vibrant yos that we have, who are always looking for ways to promote young ophthalmologists, young oculoplastics. And he was trained at LV Prasad Eye Institute, a very good oculoplastic surgeon. And our first speaker is going to be Dr. Pallavi Singh. Pallavi Singh is in private practice now at Lucknow. She was trained at RP Center in New Delhi and did a fellowship at UCLA under Dr. Goldberg. So again, another very good oculoplastic surgeon with a very good presence on social media. So I'll just invite Ayushi to introduce the rest of the speakers, and then we'll have the first talk with Dr. Pallavi.
Thank you, Dr. Rituja, organizing everything, for having me and bringing all of us together. Our second speaker is our dynamic Dr. Prerna Tahilyani, who's also the founder and consultant at the Mumbai Eye Plastic Surgery. She has completed her fellowship at LV Prasad Eye Institute, followed by her training at the Jules Conn Eye Hospital. She has conducted several instruction courses, lectures, and meetings, and has been a part of the Asia Pacific Society of Plastic and Reconstructive Surgery, ISOO, WOC, and AIOS. She's also the editor of the book Orbit and Oculoplastics, and she'll be enlightening us about fillers for novice oculoplastic surgeons today. Then we have Dr. Adit, who's a dual fellowship trained, ESOPRIS trained ophthalmic plastic surgeon, also the co-founder of the Mumbai Eye Plastic Surgery. He has done his master's at PGI Chandigarh, a fellowship at LV Prasad, his international stint at the UCLA his main areas of interest is cosmetic eyelid surgery, thyroid eye disease, and revision eyelid procedures. He has won several awards and published extensively, and he'll be talking to us about a very common aesthetic issue that we address in our day-to-day lives, that is the management of xanthelasma. Then we have the one and only Dr. Tarjini Dave, who's a big clinician, researcher, surgeon, educator, mentor. Currently, ophthalmic plastic surgery and facial aesthetics at LV Prasada Institute, also the associate director at the Kalamanji Reddy campus. Her main area of focus is facial aesthetics, rejuvenation, orbital reconstruction, and thyroid eye disease. She's also one of the very few who's involved in the translational research in orbital diseases, has published extensively over 100 peer-reviewed publications, has been the invited faculty nationally and internationally, and is currently the Joint Secretary of the Oculoplastics Association of India, and also serves as the board member at the APO Leadership Development Program. She'll be sharing some pearls about upper eyelid blepharoplasty today. Then last but not the least, we have Dr. Preeti Uday, who's the medical director and head of oculoplastics at the Oculoplasty Hospital, Chennai. She's also the global examiner for FRCS at Glasgow and an Asia Pacific faculty at AOCMF. She has a special interest in facial aesthetics, orbital trauma, virtual planning and navigation guided surgery. And she'll be sharing a few pearls about lower eyelid blepharoplasty today. Welcome, all of you.
Thank you, Ayushi. Welcome. And first, we'll have Dr. Pallavi, who will be breaking down botulinum toxin and its uses for young ophthalmologists. You're muted.
Yeah. Is my screen visible now?
No, I don't think you've shared it yet.
Hold on. I tried. Let me just see. Okay. Okay.
Yeah.
I think it's visible, but I have like 100 tabs open, so I think this is the one. Am I audible?
Yes.
Okay, perfect. Is this visible now?
Yes.
All right, perfect. Thank you so much, Rituja, for the opportunity, and Ayushi for moderating for us all the way from Australia, and of course, the Young Ophthalmic Society. And let's just get into it. This is going to be a bit of a primer for all the young ophthalmologists who are trying to start botulinum toxin in their practice. We're just going to give you a little bit of a brief about how this is done, how you can start, what are the basic things you want to look at when you're trying to start this practice. So just to go over the overview of what we're going to look at today, we're going to briefly look at how this drug came about, what are the indications, both functional and cosmetic, what are the products available, how do we reconstitute it, briefly touch upon the injection sites when we're trying to start botulinum toxin injections in our practice, what are the precautions, and then just take home messages for you. So I never skip out on the history of Botox or botulinum toxin, is because it was discovered by ophthalmologists. It was Alan B. Scott in California who sort of came up with the use of botulinum toxin for strabismus. So I feel like it is our right to sort of reclaim this injection and use it to our maximum capacity, also because we're microsurgeons. So I think we're in the best possible position to do this. And the cosmetic uses, of course, first started after the catheters, reported that in 1992, and they've never looked back since then. It's a $1 trillion industry, and everyone's trying to sort of get their share. So I'm briefly going to talk about where are the places, especially with relation to ophthalmology, where we can use Botox. I'm just going to be using the term Botox because it's shorter to say instead of botulinum toxin, but that is the brand name. The generic name is botulinum toxin. So we're going to be talking about the functional uses and where we can, if you want to start a cosmetic practice, where we can sort of take these uses and modulate that into a cosmetic practice, so to say. So blepharospasms is something we've all seen in our residencies, in our fellowship programs. Blepharospasm is the most common use of Botox in our practice. It can also be used in cases of mild strabismus, in cases of eyelid retraction, when it comes to thyroid eye disease as a temporizing measure. For epiphora, lacrimal gland Botox is something which is being used more and more by oculoplastic surgeons. Entropion in some cases where there's a spastic orbicularis muscle, or sometimes when the patient cannot undergo any sort of surgery, and we can do a chemical tarsorrhaphy also with these. So we're just going to talk about the blepharospasm injections and their sites in the coming slides, just so you have an idea about where to start these injections if you've not already been primed about this in your residency. Now, cosmetic uses, this is just briefly, I'm sure I've left out a few indications, and this is just on the face. So this just goes to show you Botox can essentially be used to treat so many things. Just to begin with, if we look in the periocular area, there's the forehead horizontal wrinkles, there's the vertical wrinkles, which we call the levens, there's crow's feet on the side. We can really play around with Botox to treat mild ptosis, to treat eyelid asymmetry. Bunny lines is what we get when we smile here. Gummy smiles, lip, like a lip flip. Nefertiti lift is just to sort of lift up, your face. It's like it's a liquid facelift. Masseter hypertrophy to cause, slimming of the lower face. So there's a huge bunch of things. And why I just have a list of these is just to prime our young ophthalmologist so that they know that there is so much stuff that can be done, which is within the ambit of the ophthalmologist or the oculoplastic surgeon, if they've been trained well, in their fellowship or in their residency program. So again, in terms of what exactly we inject, I'm just going to talk about just the periocular area, which is the crow's feet and the forehead wrinkles. Now, let's briefly talk about the products that are available in India. The ones that are FDA approved are three main brands. One is, and these are different versions of botulinum toxin. You have, like Botox, for instance, is Ona botulinum toxin, and then Dysport is going to have another variant, and Xeomin. So these three, I'm not sure if Xeomin is available in India yet. Maybe our colleagues can, guide us about this later. But Dysport and Botox is definitely available, and these are all FDA approved brands. Now, my suggestion would be if you want to start a cosmetic practice, these are the brands that you should be, going for, because, a cosmetic practice, even one complication is too much of a complication rate. So you want to go with trusted brands and you want to use these brands. For patients, if you want to start, injecting patients for blepharospasm, a lot of times they're not able to afford expensive treatment. So there's a huge range of Indian made, botulinum toxin products like Botogenie, Botulax, Stanox, which is, I think a lot of these products are being used all over. And I think this is something that you can start with if there are budgetary problems. Now, so this, I've just lifted this off of the Allergan, manual in terms which talks about how to reconstitute Botox. So essentially what you will need is you will need your product, which is either Botox if it's Allergan, or if there are other Indian products like Botogenie, you also get a saline bottle with that. And what you need along with that is the diluent, what we normally use is normal saline. And that's very important that you don't use distilled water or any other fluid or ringer lactate, because it's been known to cause pain. So you want to use 0.9% sodium chloride, which is normal saline, which is what we use. It needs to be bacteriostatic. And the tools, what you need your syringes and needles is to reconstitute. So this is important in terms of what has been prescribed by AbbVie in terms of how they reconstitute their drug. Now, different people have different ways of reconstituting it. This is how I do it. And I feel like this is what is prescribed by AbbVie, the company, which is the most commonly used brand. I think this is a good way to go about it. So if you have a 50-unit bottle of Botox, you want to be reconstituting it with 1.25 mils of saline. If it's a 100-unit bottle, then you want to be reconstituting it with 2.5 mils, which means that per 0.1 ml, you're going to be having 4 units of product. So when you're injecting, you have that calculation in your head that every 0.1 is going to have 4 units. Now, some people use a higher dilution, which leads to every 0.1 ml having only 2.5 units. Now, this changes. I have put only, On my slide, there's just one calculation, because if you have too many, then it becomes a little confusing. This is what the official company guideline is, and this is what we use. But this can be changed. So, but if you're starting off, I think it's good to start off with just one and then use that, and then you can change as you go on. Now, just I think there's not too much to the reconstitution. This is a short video which talks about it. Of course, you're going to use, you're going to open the vial of your Botox, and then you're going to draw, like this is for a 100-unit bottle. So she is drawing up 2.5 milliliters of normal saline, which is bacteriostatic. Now you want to aim at the center, there's a circle, and you want to aim at the center, and you just want to put the needle in. Now, why this video was important? Because this is a vacuum assisted transfer of the saline to the bottle, right? So you don't need to be pushing in. If you look at this, you see how the plunger is dropping on its own. So you don't really need to push the plunger whenever you're doing this. What you also need to keep in mind is that if it's not going all the way down, yes, towards the end, you want to push it in, because you want to make sure that all of the fluid is inside. Once you've done that, you want to hold on to the hub, remove it, so that you want to make sure that, all of the fluid is inside. Now, this is liquid gold in oculoplastics and in dermatology, because every 0.1 ml you lose, you're going to be, effectively, in terms of money, it's a lot of product loss. So you want to be careful in terms of how you're reconstituting it. Now, in terms of injection patterns, now this is one thing where I am going to give you a couple of patterns, but it's really impossible to cover all of that within one presentation. My request to all of you would be, if you're doing blepharospasm, try to get your seniors in residency to guide you about how to inject it. Or if you're planning to start cosmetic Botox, it's always a good idea to attend at least one workshop where you can get to know in person about where your spots are. Now, this is the pattern that we typically, that's been sort of prescribed for essential blepharospasm, where you can see on the smaller picture that there's orbicularis points on the lateral and the medial points. There's no central injection for the orbicularis, because what that can lead to is ptosis. So this is typically the pattern that we use for blepharospasm. A lot of times, blepharospasm patients also have a lot of eyebrow contraction. So for them, we can also add these central, corrugator and Procerus injections and other injections on the lateral orbicularis. So you can take pictures of these, but this is just a sort of a primer. This is not a comprehensive guide. So this is one of the things that you can sort of start using. This is a short video, which this was a video from one of the Botox, workshops that we had done at the Delhi Ophthalmological Society meeting this past month. Why I just wanted to show you this, and this is something, again, that you will learn only when you're doing workshops in person, is the direction of the injections. Now, you can also see that there's this one person who's tapping at the back. That is my form of distraction or anesthesia. And you can see that I'm doing the orbicularis injection. And I think what I'm saying to them is that the direction of the injection has to be parallel when you're doing the orbicularis, which is a superficial muscle. Again, this is going a little bit into the weeds about it, but I think why that's important is because you need to understand that the direction of all of these injections is going to be different. And now this is the Procerus injection. You can see how it's exactly at 90 degrees. So the point of this whole video was to sort of encourage you to attend some of these workshops. Now let's talk about dosage. Again, these are these elegant handouts that are going to tell you that you need 64 units for the whole area. I think that's way too much. In terms of dosage, you need to see how strong the muscle is, and you need to adjust your dosage accordingly. Typically, I use half of this. I use about 30 units for the whole face. So again, when you attend workshops, you will get a better idea about where to inject, how much of a dosage to use. Typically, these are pictures where you look at points. When you're talking about the lemon lines, this is kind of where you want to be injecting in the corrugators and the Procerus. If you're looking at the crow's feet, these are the points of the lateral orbicularis where you want to be injecting. And of course, the frontalis, if you want to be, addressing the horizontal forehead lines. What are the precautions that we need to keep in mind when we're injecting this? And again, I'm going to give you some more tips at the end of this, which is hopefully helpful. It's very important to master your anatomy. By anatomy, I mean you really need to know all of your facial muscles, how they act, and where the head is and where the origin is. So I think that's very important. For your patients, it's important to tell them to avoid alcohol or blood thinners because that might lead to increased bruising. The small things to keep in mind. After injecting, you want to put pressure on the injection sites to avoid bruising. No rubbing immediately after, because you're putting these injections at specific points. You don't want it to dissipate. You want to ask your patients to avoid any facials or anything for the next 24 hours. There's a whole thing about how patients should not be exercising. I don't think it makes a difference if patients exercise after Botox, but if you tell them that don't exercise, it also gives them, something to do, something to take care of. So you can maybe do that. So now this is again an important section that you sort of should keep in mind when you are starting your practice. Very important to use numbing or tapping. You can just tap simply with your hand. You can use one of these vibrator devices. I personally use this cream, which I've found to be very effective because I've used it on myself. No Prick Plus really helps with the pain. And so the important thing is, I know I've shown you a lot of pictures of points, but it's very important to address animation. You want to ask the patient to raise their brows, to smile, to see where exactly the wrinkles are coming. Or in cases of, blepharospasm, you want to really see which muscles are acting. Now, in this case, you can see his corrugator and procedure is acting up a lot. So you want to be injecting more in those points. So it's not just blindly injecting 4 units in this point and 2 units in this point, but also seeing how much the patient needs. If you start thinking that way, it's going to be easier. Again, customization of the injection pattern. Now, if you see, they're both smiling, but the orbicularis for this male is much bigger than the female below. So you want to be obviously injecting more units in this guy rather than the woman. So I think just keeping those things in mind. And even though I showed you a lot of spots, it's important to understand that you're injecting muscles and not specific spots. Again, check your results in 2 weeks. It takes about that much time for the sort of effect to come in. Tweak if needed. Less is more. You can always inject more. So start with a smaller dosage. You can always inject more. Like I said, anatomical knowledge extremely important. When you're starting your cosmetic practice, important to use known brands rather than going for very cheap brands, because you really don't know sometimes if it acts up, it's going to spoil your whole practice. Ideal to train with experts. Now this is very important. If you want to start this is a good primer, but you need to attend at least 1 or 2 workshops for people to exactly tell you what is the way to do these things. Less is more. Don't inject as much. And I would suggest this to all everyone who's trying to start Botox. Either inject yourself if you're good enough, but get yourself injected, because when you get Botox done on yourself, then you know what the patient feels, and you're able to deal with them in a much better way. Thank you so much. I hope I was within the time limit.
Yes, very well. And thank you so much for ensuring that we get a good attendance at our workshop as well. Very nice talk and very good for beginners, Dr. Pallavi. So in general, I would just like to ask the group that have you noticed any difference between some of the Indian brands that we used for Botox, for botulinum toxin versus the ones from abroad like Xeomin or Botox? Anybody can just, Pallavi, if you want to start.
I think the duration definitely makes a difference. And I'm talking, so I have not used any Indian brands for any cosmetic cases. That's like I said, one complication is too many complications, right? So when you're doing, especially for a cosmetic practice, I think and patients also know. So you want to give them the brand Botox, unless of course they specifically ask for something else. But for cases of blepharospasm, I think the duration is lesser, is what my experience has been. If anyone else has anything else.
I have definitely experienced that. Aditi?
Again, no personal usage with the local brands, but I've used Xeomin, Dysport, Botox, all three. All three are fairly easy to understand. Dysport dilution varies a bit. Between Xeomin and Botox, the kind of dilution is the same, but Xeomin definitely has a faster onset at about 2 to 3 days and a shorter duration, about 2 months. Regarding Stanox and all, I don't have a personal experience, but I would assume that their efficacy may be slightly lesser. Definitely in spasm patients, because they want regular injections, it's better to go for the longest acting one. And the other point I would like to just mention, I think, Pallavi, it was a wonderful presentation. Somebody can see your talk and start off their Botox. Having a comprehensive consent form really helps in the early days. So
Absolutely.
listing
Yeah.
down all the complications that can happen and taking time to explain them to the patient, especially the cosmetic patients when you're starting
Yeah.
out. So it's a good way to kind of revise your anatomy, revise what points you have to cover, and having that consent form in place is important. You can take it the first time for repeat injections, just get a sign or a date done on the same form. But first time, yes, a comprehensive consent should be taken.
I think Aditi and I had this discussion 2 years back. We were talking about how chair time is more important than table time, and that
Yes,
goes for all of oculoplastics. You
absolutely.
really want to be talking to the patients, and in general, I feel like in any practice, it's important to talk to your patients, make them understand, because anything afterwards is an excuse, right? If you tell them beforehand that this is something that might happen, then at least in their head they know that, yeah, I was informed of the possibility.
Yeah.
So yeah.
Agree. Ayushi, you want to pose any?
Yeah, I just wanted to add that pre and post treatment ice compresses are also important. Like making sure that your saline is cold and it's fresh out of the uh, cold chain, and post injection cold compresses really help a lot with the pain as well. I also wanted to ask Dr. Sumer, if you have any comments.
Yeah, Dr. Pallavi, that was a great talk, and I think I resonate with Dr. Aditi that this is a great starter for people who are interested in cosmetic or functional Botox. I just have a comment and a question. My comment would be that uh, as someone who's starting out with Botox, usually it's functional work that reaches you first, and it's the functional patients which get the confidence of, and then the second and the third Botox end up becoming a little bit cosmetic. You can interest them in dealing with things like HFS patients with a little bit of brow Botox on the other side, and that's what the patient will also ask you for. So having a painless injection experience in the first or the second time, make sure the patient gets back to you, and then also interesting them or giving them educating them on what Botox can do for them apart from their spasms is a good way for a young ophthalmologist to start off. The question would be, of course, it's a generic question, but if Dr. Pallavi can guide us on, how, if you have had any ptosis post Botox or dry eye post Botox, and that's usually what we're most afraid of. And how do you deal with that? Is there something, of course, there's no special secret formula, but what have you had in your practice and how can you help?
I just got my first doses 2 months back, so it was very traumatic for me. And
Sore point,
invariably,
yes.
it's what's the name of that law where it's going to be with someone who's super important, who's always in the public eye.
Yeah.
So it's just it's tough. I think it's tough for the doctor also, because we don't have Upneek in India. So you can use brimonidine. You can obviously you need to have good mentors, because someone needs to be calming you down also, that it's fine, it happens. But I think using brimonidine can help. I was personally also thinking of doing a little bit of orbicularis Botox to help to open the eye. But I think a lot of times they're not willing to get any more injections, once this is something that has happened, and then they know that if this doesn't work out. So I feel, I mean, I didn't do any orbicularis injections for her, but I did give her brimonidine, and you really need to be in touch with them. They need to know that you're there for them and you've not abandoned them. But it's a tough thing to deal with.
So
And you can only know the pain once you've dealt with it yourself. So I've now dealt with it, so I know it's a traumatic process for everyone.
Actually, it pays to before you do the Botox, to especially in older patients, to see if they have any pre-existing mild ptosis also, because those are the people who get the ptosis first. If they have to get, so it's you can just warn
But
them.
sometimes it's also random. Mine was a very young
Yeah, it
patient
can be random,
in the public eye, and it was just it's always these ones where you have to really. So I think, just again, I feel like a lot of aesthetic oculoplastics or any aesthetic practice is a lot of psychiatry as well. So you really need to talk to your patients. I think that's just something I feel, because we're all practitioners, we've been trained at good fellowship programs, so it comes naturally to us. But people who are starting out, people who are training in government hospitals, they need to know the importance of really spending time with your patient, because that's the whole difference between them choosing you again versus going to someone else.
That's right.
Thank you so much, Dr. Pallavi, for the wonderful presentation as usual and for the great discussion. Up next, we have Dr. Prerna Tahiliani, who will be discussing with us the art and science of dermal fillers. Over to you, Dr. Prerna.
Yeah, hi. Good evening, everybody. I think that was a fantastic opening for the meeting, and I'm going to move on to the next talk, which is going to be filler injections for the new ophthalmic surgeon. In my personal experience, I believe that general ophthalmologists should also take up injectable practice. I don't think it's a very tough job. So we'll just break it down. This is just out of my experience. Now, when you look at aesthetic goals that people have, you'll always have a spectrum and there will be people at two extremes. It's important in injectable practice to have some restraint and sort of target your outcome somewhere in between. You do not want extreme situations, and you also don't want people looking like caricatures. Now, we talk about filler injections very often. I'm not going to go into the details of rheology, but there are four things that will help you understand the choice of product that you need for the particular area that you're treating. So, fillers are hyaluronic acid gel-based injections. Now, they are either the cross-linking between the hyaluronic acid is more dense, which makes it a firmer product, or they are low-density cross-linked products, which are always great to use around the mouth, the lips, or around the eye. And G prime is something that defines how resistant the filler is to external deformity. So high G prime means that the product can bounce back. So wherever you want a little more structure building, that's what you will use. And low G prime is for the softer mobile areas. Before we start looking at what fillers can do on the face or in the periocular area, the most important thing in filler practice is screening the aesthetic patient. There are certain kinds of patients that you probably don't want to touch or you don't want to treat. So we'll look at these step by step, then we assess the patient in front of us, and some clinical scenarios I would discuss, and probably some red flags or signs where you fillers would not benefit. So, sociopaths, basically manipulative patients who differ in their behavior with the staff and differ in behavior with the surgeon. They are too pally with you, they are excessively charming, and they are dissatisfied with all their previous physicians. And they come to you saying that you're the only one who can solve this, and I've had like XYZ unhappy experiences. So, these are all red flags. Depressed, anxious patients, patients who bring in pictures or unreal model photographs and tell you that this is what they need to look like. So these are definite red flags in your initial days being young ophthalmologists. Maybe you will be tempted to try the injection for them, but be rest assured you will be one of the physicians who they are not happy with. So for peace of mind, I would usually not touch them. You should also try to pick up some cues, your feedback that the staff gives you, that, if the patients are hostile or they are too emotional, they bargain outside for the price, they don't pick up the calls, they miss the appointments. So these are again some red flags. Then again, people who come with agendas in their mind or who know too much, who've looked everything up on Chat GPT, who put up their pictures and tell you what exactly they need or where you should be injecting. I think we are better off by not taking them on as patients. Now, when you assess the periocular area, there is a lot that you can do. And with age or with wear and tear, usually we know that there is fat deflation and descent, and there is unveiling of the bony hollows. But when you look at the periocular area, you could divide it in a couple of units, like the eyebrow area, which is in continuum with the temple, the upper eyelid sulcus or the fold or the orbital hollow, and the lower eyelid and mid-face junction. So dividing the patient this way will give you important landmarks, or it will give you a plan as to what could help with enhancement in the patients. Some other things that are more important now is Pallavi discussed about, how in the muscle you have to be horizontal in the orbicularis. So based on the skin quality, you may decide what kind of filler you're using, whether you want it superficial or you want it deeper, how the patient expresses the bony asymmetry that already exists, mild ptosis, if it has not been detected by the patient, eyebrow fat pads. So these are a couple of things you need to do a whole sort of check in the periocular area. Whether the canthal support is adequate, the patient has any malar mounds or tendency for fluid retention, then these are some patients you may want to screen out. Now, these are the hollows that we generally look at where the septum attaches or the below the orbicularis roll. Then you have the tear trough hollow or you have the zygomatic line. These are some of the areas that are amenable to subtle improvement with filler injections. After you've screened out and assessed the patients, you may want to take some standard photographs in the straight and the profile gazes. Looking at some of the clinical scenarios, so where fillers help or where you could start using them is patients who are definitely concerned about dark circles. Now we live in an era which is buzzing with social media and Google activity. So a lot of patients who have dark circles, maybe not for the right reasons, may come to you and tell you that, doctor, will filler injections help us? So you have to know that the dark circles, because of the shadow effect or contour abnormalities, are good candidates for filler injections or improvement. So this is a patient, she's fairly young, and this is a 2 week after under eye filler injection. You can see that completely lifts up the periocular area. I've done a limited upper lid skin pinch for her. Now, there are some patients who will also have bony hollowing and the orbital fat sort of starts prolapsing or pseudo prolapsing or unveils itself. So you have to be a little cautious about what is the thickness of the skin in that area, whether the product will show, and counsel the patients accordingly. Sometimes, if you're skeptical, I think with experience, a good point to start would be the junction or the confluence between your orbital rim and your zygomatic ligament. So you could stage it in 2 sittings. You could start with that, see what kind of improvement you get, and then go back as a second sitting and address the medial hollow. This is a patient who has contour abnormalities because of a previous intraregional steroid that was given by her dermatologist for acne, which ended up with hollowing the under eye. And this is 5 minutes after the filler injection and 2 weeks after filler injection. Now, sometimes mild to moderate eyelid bags respond to fillers, though this is not my favorite thing to do, and I have a very low threshold to counsel them for surgery. But sometimes patients, if they understand the pros and cons and the longevity of the result, if they push you, you can sort of buy them time with the help of a filler injection. So here I've done a little bit of modest filler in the under eye and maybe a drop or so below the brow in the medial sulcus. This is a 1 or 2 week after result photo. Sometimes they work very well in combination with surgeries, with upper eyelid blepharoplasties or even lower eyelid blepharoplasties, and you could do a little bit of treatment of the malar regression with fillers. Eyebrow fillers are this is one of my favorite areas, in fact, in the periocular area to treat with fillers. I don't so much so do a lot of under eye fillers now. So a little bit of bony unveiling or descent of the tail where you lose the 3D contour of the brow fat. These patients do very well with filler injections. This is another patient with modest filler done in the under eye in a gradual stepwise pattern or the perioral area as well, and a little bit to support the tail of the brow. And this is her final result after 4 ml injected over the consecutive 2 years that I had seen her. Now, this is a paper which was from the UCLA group. Dr. Hamza has written it, and Adit was one of the co-authors. So, in the Asian profile, you can have this typical A-shaped deformity where you lose the medial, you start showing the medial sulcus, and if you don't have very significant orbital fat prolapse, filler is a good option to fill in the brow fat span or the sulcus. Now, I mentioned that there are some patients where fillers don't work very well. So this is a patient who has a lot of periocular pigmentation. And you may get tempted to try filler injections or skin boosters, but be rest assured that's only going to highlight the skin change and will make her look a little more raccoonite than what she looks. There are patients who have extremely thin skin and fluid retention or cyclical congestion or fluctuating fat prolapse. So in them, filler is definitely not a great option. She's one of my earlier cases where there was a little bit of Tyndall effect and you can see the product there. She was obviously not very happy. We just let it stay and let it get dissolved on its own. This is another patient who has allergic eye disease, and he would frequently have eye allergies or break up in hives in the periocular area. So, this is a definite no for filler injections because that will only compound to the fluid that the under eye holds. So I try to keep it short. There is a lot more that can be discussed in periocular fillers. And like Dr. Pallavi said, so recently we have started holding these workshops. And if anybody is interested, you can always contact Dr. Adit or me. Thank you so much.
Thank you so much, Dr. Prerna. That was a fantastic presentation. Dr. Sumay, do you have any comments or questions?
Yeah, Dr. Prerna, that was a wonderful presentation. I think a great way to get people interested in periocular rejuvenation. I have a couple of questions for you. The first would be, as somebody who is now nearly into a decade into practice, you have also started performing blepharoplasties on patients you might have done fillers for in the past. So, how do you see fillers and the whole debate on filler migration or filler always being there in our face after it being injected, and does it really affect your surgery in any way?
So my key sort of guideline would be that dissolve whatever filler is remaining. If it's 5 years ago or if it was 8 years ago, it doesn't matter. And I think you can clinically pick it up. You assess old photos, and sometimes they come up with malar mounds, and patients may not know that that is because of the under eye filler or it has got augmented because of the under eye filler. So dissolving and starting on a clean slate with assessment and then deciding, what kind of blepharoplasty you want to go ahead with would be my go-to suggestion for this.
Yeah, and of course, another debate, which is the cannula and needle debate. Do
Mhm.
you feel like there is any discomfort with any of the two? Is a patient more comfortable, and what is your preferred mode of
I
injection?
think the patient is not really uncomfortable with either. It's a very surgeon-based kind of personal preference. I have used both. And now I think a lot more people sort of propagate the cannula over the needle. But in my experience since back from fellowship, maybe since 2016, I've not had any kind of issue with the needle. And that is something I prefer because there's less resistance to go to the plane that you want to go to, and there is less sort of manipulation with that.
Yeah,
I
absolutely.
think more than the cannula needle, it's the aliquots or the volume. So you either fan it out, you thread it out. I don't do so much of threading, but micro boluses, just a little bit, like Pallavi said, less is always more in aesthetics. So knowing exactly in the 3D contour where you want to deposit that little bit bare minimum filler to give the maximum purchase out of the
Yeah.
procedure.
Thank you, Dr. Prem. And I love that you started when not to inject, then when to inject. I think that's the biggest takeaway from this talk.
Yeah, yeah.
I think I can just add one comment. Ma'am, excellent presentation as always. Always so much to learn from you. So regarding the pigmentation and the hollowing, a good
Hmm.
idea is to take a photograph with and without flash. And you can
Yeah,
explain to the patient that what is disappearing with the flash will benefit from the filler. But whatever
yeah,
pigmentation remains despite the flash being on, that's your skin texture, skin tone. That's
yeah,
not going to go away.
yeah. True.
Thank you, Dr. Prerna. Great talk, and thanks everyone for your points. So, Dr. Prerna briefly touched upon the under eye and that region. So, that was the non surgical. Now, we'll have Dr. Preeti, who's been kind enough to join us despite being at the airport. So, she'll be talking about lower eyelid blepharoplasty and fat transposition. Go ahead, Dr. Preeti.
Thank you so much for accommodating me like this in the middle of everything. And thank you very much. I would love to spend this evening with all of you a little longer, probably, but I can't do that today. So I'll be speaking on lower lid blepharoplasty with fat repositioning. You all can hear me, right? Yeah?
Yes, yes.
Okay. Okay. So now, whenever you have the lower eyelid, you need to assess if you have excess of skin.
If you have excess of skin, I prefer to still go transconjunctival, but do a skin pinch and remove the excess of skin that you want. Because when you do a whole lot of dissection from the anterior side to remove that small skin that you need to remove, you will land up with an ectropion or lid retraction because that whole dissection pulls the lid down in the post-op period. So my preferred approach, even if the skin is excess, is transconjunctival and then just remove the excess of skin with a skin pinch. Then you also need to assess if it is a real fat prolapse or if it is a malar festule. Okay? And how you assess that is that all the fat prolapse will be in the eyelid. Okay. So ask the patient to look up, and if the fat gets more prominent in up gaze, it is a fat prolapse. Whereas the festule remains the same in up gaze as well as in the straight gaze. Okay. And the festule can extend beyond the orbital margin like this. If you see, all this fluid bag is in the malar area, which is much below the orbital margin compared to a fat prolapse, which is restricted by the orbital margin. This is very, very important because for a fat prolapse, you're going to operate, but for a festule, you will avoid surgery because festule is like a sponge which absorbs all the fluid. And if you have a festule and if you're going to operate, it's going to increase in size and worsen with the surgery. And therefore, you need to really assess this very well. And if you have a doubt in this, please ask me. Also, you need to assess the lateral canthus, whether it is loose, it is downward displaced, or if there is a negative vector. Now, what is a negative vector? Basically, the patient's eye is more prominent. Your malar prominence is behind the cornea, okay? So if there is a negative vector, that means if you're going to tighten the lower eyelid is going to retract in the post-op period. That means if the patient's eyeball is prominent, it's like tightening a pant on a pot belly. The pant is going to slide down, okay? So in that case, if you have a negative vector, avoid a tightening procedure. What you need is a lid lengthening procedure, that is the lower eyelid correction, or you need a decompression, bring the eyeball inside, okay? And also the lid laxity. If the lid is lax, you need to tighten it. So this is a typical festule, and this is the problem with the negative vector. So this is a patient typically having a negative vector. You can see the eyelid is retracted post transcutaneous blepharoplasty because what she needed is not a lid tightening in this procedure. She needed a little bit of decompression along with the blepharoplasty. And these patients, especially, you should do a transconjunctival blepharoplasty. So now there are two ways of dealing with the fat which is prolapsed. Either you remove the fat. Now, if you have too much of fat prolapse like this, he has got a lot of fat prolapse. If you're going to remove all of it, he's going to have this hollow. So if there is a little bit of bulge, I'll come to that later when you do a fat excision and when you do a fat repositioning. So these are the two ways in which that you treat the bulged fat. So in a fat repositioning, which I'm going to talk today, you need to reposition. So you create pedicles from the prolapsed fat and position it over the inferior orbital rim so that it creates a smooth lid cheek junction. The bulge is not seen, but at the same time, you're correcting the volume deficit. So you're adding volume to the lower eyelid and avoiding the hollowness that it creates. Okay. So this is how a fat repositioning is done. You take lid traction sutures initially. You make a conjunctival incision in the fornix and then dissect the fat pedicles out. You will see that the medial fat pad is whiter, a little paler compared to the central and the lateral fat pad. And you will find the inferior oblique in between the medial as well as the central fat pad. So here you can see the inferior oblique very clearly. You can see my cursor, right? So this is the two fat pads, and you separate all the septa in between so that there is a smooth gliding between the two fat pads. And that prevents the post-op diplopia that can happen sometimes because of pull on these fat pedicles. Okay, then I do a pre-periosteal approach. You can also do a sub-periosteal approach. So here I am releasing the orbitomalar ligament, and that I do with a sharp dissection. And then you place these fat pedicles in the pre-periosteal place. So you create a pocket in the pre-periosteal space where this fat pedicle will get repositioned. Here I'm using a 7-0 proline suture on a long needle. This I got from Korea. You don't get this in India. But you can use any of the sutures. Basically, the point is that you want to keep the fat pad repositioned at least for 5 days. So I keep this for 5 to 7 days and I remove the sutures after 7 days. Here, what I'm doing is I'm taking one suture on the medial end of the medial fat pad, then combining the medial and the central with one suture, and the lateral end of the central fat pad as a lateral suture. I excise the lateral fat pad because it's very difficult to pull it over the inferior orbital rim. It's a little shorter, and so it tends to retract back, and it's much deeper to dissect. So it's better to remove off the lateral fat pad. And either you close the conjunctiva or leave it as it is. So here I'm closing it with one or two sutures. Okay. Now here I have not used any bolster for the sutures because the sutures are very thin 7-0. But if you're using higher sutures, then you need to at least use some bolster. Sometimes I use the pad which is available in the suture material. You know, those packing has got a small fat pad, or you can use a Merocell sponge like I'm using over here. So this is the same video, but I just wanted to show you that I'm using a Merocell sponge in the end. Sorry. Okay, so I just go to the next slide. Okay, so you can use a sponge in the end, and then you need to tighten the eyelid. Most of the lower eyelid cases, you need a closed canthoplasty like this. So you make a nick at the gray line, and then you go through the gray line and come out through the periosteum in the superolateral orbit. So that's how you can tighten the lower eyelid in a mild to moderate laxity without opening the lateral canthus like a latex acid strip. And this is the suture that I'm taking. So most of my cases, I'd like to do the suture so that the lower eyelid gets tightened. Okay, so that's how it is done. And then you can do this if you have a blepharoplasty incision, or you can make a small incision in the lid crease in the superior eyelid. And at the end of procedure, you can either do a PRP or you can do a PRF injection to improve the skin, because here you're treating only the fat bags. If the skin is crepey, if there is laxity in the skin, you can improve the skin by doing a PRF or PRP, or you can also do nanofat. I do CO2 laser and then use a nanofat as the absorption of nanofat will be much better if you do it after making the openings with a CO2 laser. And you need a compression dressing for at least 24 to 48 hours at the end of the procedure. Now, this repositioning I'm doing with barb sutures so that you don't have a dressing on the outside and it reduces the downtime for the patient. So this is the barb suture that I use. And I do IPL on the second or the third day, and I repeat it twice or thrice at least, so that IPL, the chromophore is water as well as blood, and therefore you have post-op edema and swelling coming down much faster, and the downtime can be reduced very fast for these patients. So IPL is available, you have it for the dry eyes, and the same, you can use it, and you can see that second post-op day, the patient is quite comfortable with less edema, and there is no suture hanging out because I've used a barb suture. Also, sometimes the fat that is available for repositioning is not enough and you need to add fat. So you harvest the fat. I usually harvest from the inner side of the thigh, and then you can process it depending on how you like it. I like to decant it and then reduce it from 2.4 to 1.2 millimeter in size. And then I inject with low pressure in various areas of the midface. So if you augment the midface, the lid cheek junction becomes like a nice continuous junction. You can reduce it to even 1 millimeter and use it like a nanofat. So these are few of the results with these repositioning. You can see that you have retained the volume. The patient looks much better compared to excision completely. Especially in these kind of eyes, which are from the northeast, it is very, very useful because their maxilla is hypoplastic little bit. And also in these kind of patients, you can see the mid-cheek junction is quite good. And another way, now the drawbacks of this procedure is sometimes you can have diplopia if you're not dissecting it well. There can be persistence of dark circles, fat granulomas from ischemic fat, and prolonged edema in some cases because you're dissecting way below, and also soft tissue irregularities. And the most biggest problem I find is that sometimes, even if the bulge is not there, you can still have a demarcation line in that area. And it has a steep learning curve. So this is a good treatment which is devised by Dr. Tanuj Napra, wherein he lifts the midface and also does a repositioning. In that way, from both the ends, you are treating that deep hollow, especially when it is a very severe condition. That is really helpful. You take few midface lifting sutures before you do the repositioning, and that is a very nice technique. And the other way is you just remove the fat. That is, whatever fat is prolapsed, you excise it and then you augment the volume with a fat transfer. So that reduces the downtime. It's much easier. But the problem is that there is a change in volume of that injected fat with pregnancy and in the perimenopause period. And it is little unpredictable because whatever fat that you're going to inject, it may not stay or it may not survive completely. So it's little unpredictable. So these are your two options which are available, and you have to decide based on your patient profile. Thank you very much for this wonderful opportunity and accommodating me in between your sequence. Thank you.
Thank you so much, Dr. Preeti. I think that was a talk which had like 100 pearls. So we'll all have to go back and refer to it every time we want some new tips. And also, what is your tip for not having a disturbance in the sound when you're at the airport?
Oh my God. So I'm just using noise cancellation and sitting in an
Okay.
area which does not have music, one
Okay.
of those lounges.
Must keep that in mind. I think Dr. Aditi has also started doing the SMAS lift along with the lower lid blepharoplasty. So if you want to comment on that, Dr. Aditi.
Excellent talk, ma'am. You make it look so easy, but we all know how the learning curve is so steep. And seeing your videos, it's just fascinating and amazing how well you do it. Thank you for sharing your pearls. So the paper that you referred to, yes, it's a good starting point because if you're combining a mid-face lift, a SMAS lift, I think then the repositioning is primarily, I mean, I just prefer to do the medial repositioning. So maybe the medial end of the central fat pad and the medial fat pad can be repositioned, and the lateral and the central, the rest of the central, I kind of excise. What I wanted to ask, because we discussed malar festoons, but hypothyroid patients who kind of do develop a lot of edema, they may not always have the thyroid eye disease like we classically see in Graves. In those, do you feel that an excision, because it serves like a decompression as well, and kind of if you're putting fat over there in the mid face, it will contribute to lymphatic changes over there. So would that be a relative contraindication for this in your practice, or
So yeah, this is a very challenging condition because you have pros and cons which I discuss with the patient. Number one is that these patients have prominent eyes and they have kind of a negative vector. So if you're going to excise and then augment with a fat grafting, it is a very prolonged post-op period. And the fat may not be enough because they have the tendency to increase inflammation in the post-op period. I prefer a fat repositioning only in these patients, but I always tell them that if a normal patient is going to take 2 weeks to improve, you're going to take 3 months to improve. So if you prepare them in the beginning itself, the procedure, I think fat repositioning is much better than a fat grafting for them. Because they have a negative vector, you need that augmented volume, which you can't predict with a fat grafting. Of course, you need to sometimes augment with a graft also, but I don't do a fat grafting initially because then I have a second procedure in hand in case you need some more later. So preparing them is, I think, what is important because they will have a prolonged post-op period. Make sure that they are like in the inactive phase for a long time. They are controlled very well, and they are prepared mentally that they are going to take longer to improve.
right, ma'am? That's then chair time is more important than table
Yeah,
time.
yeah,
And ma'am,
yeah,
just
yeah.
last quick question: which IPL filter do you use for the bruise as well as the swelling
The
combination?
same 500 nanometer that you use even for dry eye. So what I do with blepharoplasty patients is that I do one IPL before the surgery for the dry eyes because they have the dry eye workup and a dry eye treatment pre-op itself really helps them in the post-op period. And post-op, we have seen all our cataract patients, all our blepharoplasty patients, they have mebuminitis, they don't clean it well. So IPL helps in that also. So it helps you with the dry eye also. And it does reduce the edema and ecchymosis. You keep it at the lowest setting that you have on your machine because, of course, inflammation is there and you don't want to keep it at a high setting. And the patient choice, patients, how you choose your patients. Fitzpatrick 4 to 6, I'm not going to do it anyways. So 1 to 3 is what you will prefer. But I have seen tremendous improvement in their edema and in the downtime that it can reduce beautifully. You just do one IPL, next day edema is gone, the bruising is gone. It's beautiful with the lowest sitting itself.
Thank you, ma'am.
Great
Thank you
tips.
so much.
Yeah.
Thank you.
Thank you so much, Dr. Preeti, for the excellent talk. Now we'll move on to the upper eyelid, and we have Dr. Tarjini Dave with us now, and I would like to invite her to share her pearls about upper eyelid blepharoplasty.
YOSI, Ayushi, Rituja, Aditi, everyone here. Thank you so much for having me. I'm audible, right, Ayushi?
Yes, yes.
Okay. So I'm going to take you through upper eyelid blepharoplasty, and compared to lower eyelid blepharoplasty, this is a much simpler surgery. It's often considered as, a beginning of your aesthetic practice, and it's probably one of the most common surgeries that a resident in the United States is sort of ophthalmology resident is trained in. And it's quite simple in essence. You mark the excess skin, you excise, you close. But then the difference between an operated eyelid and a beautiful eyelid is everything that happens before that incision. And that's where I think the repetitive concept of the chair time is more important than the table time possibly comes in. And with that in mind, I thought I'll take you through how you preoperatively simulate to the patient what is the expected outcome, the anatomy of the upper eyelid, the surgical marking, which is essentially your design, and then the execution of your upper eyelid blepharoplasty with a few modifications that you can bring in to improve the final aesthetic outcome, and then show you again post pictures of patients that we've operated. I don't have financial disclosures, and I have the consent in place for the patients whose pictures you'll see over here. So let's begin with the preoperative simulation. What essentially you can do is use these simple devices. You can use a U-clip and sort of just straighten it out, or use a Bowman's probe, or even use a curved probe. And this is a patient who has an asymmetry in the pretarsal show, as you see over here. And for some reason wants it corrected. And just by the placement of that probe, you can show the patient how you can symmetrize the tarsal platform height, or in fact even get inputs from the patient, because they would want to look a particular way as far as their upper eyelid is concerned. In all of these surgeries, I think even before you do this preoperative simulation, it's a great idea to ask them for their old photographs. And with everyone having a smartphone these days, it's not very uncommon for them to be able to pull up relatively good resolution old photographs on which you sort of get an idea of what they look like, because patients always want to go back to how they looked rather than drastically changing their appearance. So these few tricks preoperatively certainly help you in executing the best outcome for your patient. Now, as far as the anatomy of the upper eyelid is concerned, you need to understand that in a male and a female, this anatomy is slightly different. You have a female on this side of the screen where you see a beautifully arched brow, and then you can see that these patients tend to have a higher lid margin to the lid crease or the tarsal platform show. So in these patients, when you perform your eyelid marking, you're actually going to make the patient look up and down and figure out where exactly the crease and the fold are forming, and then make your mark. For some reason, if a patient has multiple eyelid crease, then this tentative figure of about 8 to 10 millimeters helps you understand where exactly your marking should begin from. And in men, on the other side, you'll see that the lid crease distance is usually lower compared to that in women. It's not only the distance of the tarsal platform, which you see in these two young patients here, a male with a shorter tarsal platform, a female with a, relatively good height to the tarsal platform, which actually shows the makeup in the upper eyelid, but it's also the brow. If you look at a male brow, it's typically flatter, and compared to that, you have a very arched female brow. And these points are important to understand if you're going to perform skin excision in these patients. You'd want to maintain it in such a way that you're not really disturbing the balance. Now, in the upper eyelid, unlike the lower eyelid, you have two fat pads. You don't have a lateral fat pad in the upper eyelid because that space is actually taken up by the lacrimal gland. But sometimes you may see that the lateral part actually looks very droopy and a patient may have a prolapsed lacrimal gland. And if you're doing an upper eyelid blepharoplasty in these patients, then you may take that opportunity to reposition the lacrimal gland back just within the orbital rim so that it gives that nice fullness to the lateral brow, and you've treated the prolapse in these patients. Sorry. Okay, so the between the medial and the central fat pad, the medial fat pad is essentially lighter in color, and that helps you identify the medial fat pad. The central fat pad is a little more egg yolk yellow in color. Now, I spend a lot of time in the surgical marking for the upper eyelid blepharoplasty, and what I've drawn over here is just, a rough landmark that you typically start by marking your incision at the eyelid crease. You then decide or decipher what is the excess skin in the upper eyelid. As a rule of thumb, you want to leave back 20 millimeters of skin in that eyelid to avoid exposure keratopathy and to avoid excessive skin excision. And therefore, all that excess then becomes the height of the blepharoplasty that you're going to excise. Typically, you'll have a little nasal taper and a lateral flare. You also need to understand that laterally the eyelid crease has an upward slant. So you're actually going to have a inferior point nasally and a relatively higher point temporally to match the eyelid crease. And you can look at that on the unmarked side in this lady, where you see that the crease typically is lower nasally and higher temporally. So this would essentially be the marking in any upper eyelid blepharoplasty. If you have a much older patient with a lot of dermatochalasis, then you may want to extend beyond the line which joins the lateral canthus to the brow to sort of have complete excision of skin on that side. But otherwise, for younger cosmetic patients, keep your incision within this line, because in that situation, as the patient keeps the eye open, the surgical incision will not be visible. It will be hidden exactly within the fold of the upper eyelid. And it's always a good idea to sort of, do this and demonstrate it to the patients as well, but also for you to understand that you can pinch the amount of excess that is present, and then ask the patient to close his eye and watch for lag of thalamus. As you develop lag of thalamus, you'll get an understanding that, okay, this is too much skin that I'm excising, and probably you'd want to leave back some amount of skin. When you're doing this marking, it's a dynamic marking. Throughout the process, you're asking the patient to look down and to look up. And with that dynamic movement, you'll be able to understand where exactly your crease begins. And that's what we've done. You then determine the excess, and with that, you mark the upper boundary of the blepharoplasty incision. And once that has been done, you have your entire incision marked. You may want to ask the patient to then look up and down, and you can see that this mark completely disappears in this eyelid fold. It doesn't extend beyond the line that joins the canthus to the tail of the brow, and therefore this incision is going to be a well hidden incision. Now, as far as anesthesia is concerned, this surgery, unlike the lower eyelid transpositions, can be comfortably performed under local anesthesia. This picture I just put up to show you that the density of nerves in the central part of the eyelid is the least. And you can prepare these patients by giving some topical anesthesia with a numbing agent about 20 minutes before the surgery, and then plan your local anesthesia, and you begin from the center and fan it out temporally and nasally. And in that situation, your patient is going to be very comfortable as far as pain is concerned. So let's just quickly look at a video. This is just the initial dynamic marking where you're fanning out from medial to lateral. You determine the amount of excess skin that is present. We've gone through all of this, the nasal taper, the temporal flare, and then the local anesthesia. You can either use cold steel or you can use a radio frequency cautery for your skin incision. In Indian skin, I feel it's a better idea to use a blade because you tend to see a lot of post-operative pigmentation. And then your local anesthesia sort of gives you a plane where you can preserve the orbicularis and all its blood vessels and simply just excise the excess skin in these patients. Now, this particular gentleman, it's a male blepharoplasty. He has a lot of bulk in the upper eyelid, which he wants removed. And he also has some amount of ptosis. So you can use this same blepharoplasty incision actually to then isolate and expose your levator muscle. And that is what has been done. The under surface of the levator disinserted from the tarsus. You can see the vascular arcade here, the tarsus here. So that's your under surface of the levator, what the blue line shows in the schematic. And then you separate the septum and the preaponeurotic fad from the over surface of the levator, what the red line shows over here. And with that, you can isolate your levator aponeurosis. The rest of, here's the debulking of the fat pads. The central and the medial fat pads can be isolated and debulked. I like to use a cautery to ensure that the spiral blood vessels which are there within the fat pads are cauterized before you sort of let go of the residual fat. So you can chase and remove as much medial fat as you require because sometimes these are difficult, these fat pockets are difficult to find in the medial orbit. And, with aging, these tend to be the most hypertrophied fat pads. And this particular gentleman also had a prolapse of the lacrimal gland, which you see over here, which is giving him a little bulk. So we debulk the fat around that lacrimal gland, and then this is the suture that is taken to put that lacrimal gland back into position or reposition the lacrimal gland. So rather than taking the sutures right through the gland, I like to take it through the fascia around it and then anchor it to the periosteum. And you can see that that gland nicely tucks in as you tighten the suture. And this helps you bring back, the prominence where it belongs rather than the droopy tail of the brow. This is a male blepharoplasty. He has a lot of hypertrophy of the orbicularis, and in that situation, I would actually debulk the orbicularis as well. But if this was a woman, I'd be careful doing it. Anytime you debulk the orbicularis, remember that you're going to give the patient a little bit of lag of thalamus. I'll skip the part where you take your ptosis sutures, but once you've done that, you essentially form the eyelid fold. There are different ways of doing it. What has been done here is the lower lip of the incision is anchored to the levator and the upper border of the tarsus, and then the rest of the incision is closed with interrupted. I like to take absorbable sutures because it saves you some chair time post-operatively where you don't have to chase suture removal. And that marks the end of the surgery. And that is this gentleman who's had his ptosis, the bulk in the upper eyelid, as well as the excess skin corrected. Here's a more younger patient who wanted his eyelid fold formed. And again, in him, we've done a bilateral upper eyelid blepharoplasty with fold formation. Yet another gentleman who's had bilateral upper eyelid blepharoplasty. He doesn't really have very significant ptosis, but it's the hooding and the weight of the upper eyelid which is making him look ptotic, which seems corrected once the excess skin has been removed. So you can have some modifications in your surgery. Here we've preserved the nasal fat pad in this particular gentleman, and just like Preeti showed the transposition of the fat pad in the lower eyelid, this gentleman has a lot of hollowing in his superior sulcus, and we are transposing the nasal fat pad to fill that hollow in the upper eyelid. This particular gentleman actually had a hollow more medial, so the central fat pad has been used to fill up this hollow towards the nasal side. And you can do vice versa. You can use the medial fat pad to sort of fill the hollow centrally. And you're using the same principles that Preeti was saying to sort of redistribute the prominence to an area of hollowing rather than excising the prominence and leaving everything hollowed. This is a patient who's had blepharochalasis, and you can tell that from the thin skin that you see in the upper eyelid. So here's a lady who's had a similar repositioning of her fat instead of excision to fill up the areas of hollowing around that fat pad, and this is her post-operative outcome. Here's another gentleman who's had a quad bleph, and again the central hollow that you see has been filled up by the medial fat pad by transposing it, and you can see a pre and post-operative outcome. He's also had a lower eyelid blepharoplasty with fat repositioning, where all these factors together have given the final post-operative appearance that he has. And just a few pictures. Sometimes what patients are looking for is just a very minor correction. They may not really pick up that there is brow descent as well, and they may not be very keen to have an endoscopic brow, which to them sometimes may seem like an overkill. So you can use the same incision in the upper eyelid to do an internal brow pexy, which is what has been done, and you can see that his brow now is elevated compared to where it was earlier. You want to be careful in doing this in a male and not feminize the upper face. Here's a patient who's had actually an external brow lift. The scars that have been taken in the form of a spindle excision above the heavy brow is pretty well hidden within the brow that he has, and he's also had an upper blepharoplasty. And then you can always combine this with excision of the xanthelasma. Sometimes just doing the xanthelasma excision is going to disturb the eyelid fold, and then you may need to extend it as an entire upper blepharoplasty. And sometimes you may need to do the reverse, where this lady's obviously had some decompression, but with that has had advancement of the pre-aponeurotic fat pad, and this is an early post-op picture. There is edema around, but you can see that that has helped in sort of symmetrizing the tarsal platform. So what has been done is the septum has been incised, and this fat is brought down lower and sutured upon the tarsus to sort of symmetrize the tarsal platform. And to conclude, the best blepharoplasty is a blepharoplasty where the patient sort of, is complemented by comments such as you look well rested rather than you look operated. And these are just some post-operative pictures of patients that we've operated. That's what I had to share, and thank you so much for your patient listening.
Thank you so much, Dr. Tarjini, for the fantastic pearls. I wanted to ask you, what are your indications of combining it with an internal brow pexy versus a direct brow lift, or just a bleph alone?
If a patient has, okay, so we've ruled out endoscopic brow. We're just discussing internal brow pexy versus an external lift. So if a patient has a relatively heavy brow, I would rely more on an external lift. And if they have thicker brow hair, to sort of hide that scar like you saw in that gentleman, then certainly I would do that. I would discuss the scar with the patient, because to some extent these scars are visible. We as Indians also tend to pigment a little more than the Caucasians, and our scars are not as forgiving. So I would certainly discuss that with the patients. But if I require just a tiny amount of lift in the brow, then I wouldn't hesitate going the internal brow pexy route. So it depends on how much of a lift, how thick the brow is, how concerned the patient is with the scarring.
Thank you so much. Dr. Sumay, do you have any comments or questions?
Yeah, thank you, Dr. Tajni. That was a wonderful talk, and that video, I think, summarized everything start to finish. We got an overview of everything that an upper blepharoplasty can deliver to a patient. So, my question actually for you, I mean, having seen you perform these blepharoplasties and these nuances that you have when you perform these surgeries on a gentleman as compared to women, you touched upon this throughout your presentation. But if you can summarize for us how your thought process changes, especially when it comes to maintaining the fullness of the upper eyelid when we are, trying to rejuvenate male upper eyelids.
Yeah, I think I'd pay a lot of attention to where the marking should begin. And typically we've seen that male have sort of a, shorter tarsal platform. So I'd pay a lot of attention to that marking where it begins. I'd certainly want to be higher on a female and lower on a male. Before doing this marking, I would actually ask for photos, and every patient I would ask them to show me what they want to look like. Reviewing their own old photos with them is an excellent way for you to plan your surgery. So these are two very important things that I do. As far as women are concerned, I'm very conservative in excising the orbicularis. They tend to have thinner skin. But as far as men are concerned, I wouldn't really hesitate in excising some amount of orbicularis and even debulking some amount of the preaponeurotic fat pad if that is in the way. And in both these subsets of patients, I'd certainly look for a lacrimal gland prolapse. It's more common than what we sort of tend to realize. Quite often it's intraoperatively that you'll realize that as you're dissecting laterally, you see the lacrimal gland palpebral lobe sitting right there. So I would pay attention to these points between a male and a female blepharoplasty. And if at all a female is keen on or has brow ptosis, I'd be very, very hesitant to perform anything but an endoscopic brow.
Thank you so much. That was wonderfully summarized. And I'm very glad we got a bonus ptosis repair video as well. So that can help the YOs to take a look at how they can perform levator reattachment. So Dr. Aditi, you can ask your questions, then we can go ahead.
I think it was an excellent talk. And like ma'am said, that the well-performed surgery versus a surgery that has been done, these nuances are what really matter. And ma'am did emphasize on the preoperative marking. So that was wonderfully demonstrated, ma'am. Thank you so much for this talk. So much to learn from you.
Thank you. So once again, Dr. Tarjani has done it again and made such an amazing and comprehensive lecture for everybody to learn from, and really grateful to you and for taking time out for us.
Thank you very much. And thank you, Adit, for allowing both of us to go before you.
So up next, we have yet another star oculoplastic and aesthetic surgeon, Dr. Adit from Bombay, where it seems all the aesthetics is happening is in Bombay. Welcome, and he'll be talking to us about the non-surgical or the surface treatments, and on special request by Dr. Ayushi, because she said his talk on xanthelasma was very well received earlier. We'll have him talk on that. I think he's gotten disconnected also. We'll wait for him to just join back once.
Meanwhile, I'd just like to make another comment on the previous talk by Dr. Tarjani. I think she very importantly told us, and Dr. Aditi also said that having a preoperative marking is very, very important. So, as somebody who's had their markings erased 1,000 times by Dr. Tarjani before a surgery is performed, I can tell you that that is the make or break of an upper eyelid blepharoplasty. So, even as somebody who is a junior, who is kind of, not probably performing the surgery themselves, I think that is maybe more important than the surgery itself. So even being very meticulous with the sitting and the lying down position, doing it twice, doing it thrice, erasing it and going back in again, even if it takes like 20-30 minutes, I think it goes a long way with the final outcome.
Thank you, Sumir.
Okay, is my screen visible?
Yes, Doctor.
Perfect. Sorry. So good, I got the last talk because my talk doesn't have too much details. I don't have many videos to show, and it'll be the shortest talk of all that we've seen in the session. But it is very important, especially once you realize and get a little bit of gray hair, you'll realize that treating xanthelasmas is relatively stress-free as compared to the high pressure blepharoplasties or ptosis surgeries, because these patients already know that the xanthelasma might come back. So, you always include that in your counseling. So it's a good procedure to do to earn some extra money from what you already earn, especially in aesthetics. So I'm going to just cover a little bit about how xanthelasmas appear, how they sort of are classified, and our understanding of xanthelasma till now in whatever we have done. So, this is a classical xanthelasma where you see lipid-laden histiocytes, or commonly called as foam cells, in the superficial to middle dermis. So it's very important to know the location. It's beneath the epidermis, it's in the superficial and the middle dermis, unless and until it is touched. Now, it's not a fairly completely benign process. There's a lot of underlying inflammation and fibrosis which goes on in the xanthelasma. When you do a histopathology, you'll realize that. And it's mostly concentrated around the perivascular arcades in the dermis. So that means the blood supply which is there is bringing these foam cells and causing deposition there. Around a 50% of these xanthelasmas are mostly because of hyperlipidemia, but the other 50% are because of elevated lack of enzymes which digest LDLs and other lipid which is present in our body. This is how a xanthelasma looks when it is touched or when multiple procedures are performed. You can see a variegated appearance where there are more sort of yellowish areas of atrophy, and then areas of fibrosis, hyperpigmentation, and then areas of disappearance. So this is a very complicated scenario to treat. Let us see what treatment options have been reported in literature and what we all do. Now, if you look at this review of xanthelasmas, you can see that there are multiple treatment options which have been tried. Majority of them are tried by dermatologists. But the three options that work well, in my opinion, are a spot peel or a TCA peel, which is trichloroacetic acid, carbon dioxide laser along with radiofrequency ablation, and then surgery, which we all like to do. The other lasers like the erbium laser and all are widely used in the US or the West, but not very commonly used in India. We have started using Q-switched Nd:YAG laser recently for xanthelasmas, but right now carbon dioxide laser seems to be the most appropriate option. Now, as I told you that we'll zoom in to three more definitive options. I'll be talking about surgical excision along with RF ablation and a little bit about CO2 lasers as well. Now, what is the mechanism of lasers? So if we think of lasers, how do you sort of justify what it does to the xanthelasma? Basically, CO2 lasers or erbium lasers are ablative lasers. They go inside the skin beneath the epidermis into the dermis and cause destruction of the cells, leading to phagocytosis, lipid breakdown, and then absorption by the blood vessels. On the contrary, TCA peels or spot peels usually lead to surface chelation and fibrosis, which we'll see in the coming. Now, the next few slides will be basically discussing about surgical excision and RF ablation. But before that, we need to understand that xanthelasma also can present with different morphological types. There is certainly a subtype which is called as the plecoid or the nodular lesion, which is the most easiest to treat. The second subtype is the macular lesion, where it's not elevated above the skin surface. It's a flat lesion, mostly at the level of the skin surface. Third, lesions with dermal atrophy or damage because of previous treatments, which is seen here, where you see a central area of atrophy and a surrounding area of yellowish deposits. Fourth, in these lesions, in these cases, usually excision is the most definitive treatment. And then there are recurrent lesions where multiple treatments have been done. They have responded to those treatments and then they recur along with fibrosis and lack of skin, especially after surgical excisions. These are very amenable to RF ablations or laser therapies. Now, these are some pictures where I'm showing how surgical excision works for xanthelasmas. It could be a limited excision, which is the most commonly performed, because when these patients come into your clinic, they're very focused on getting the xanthelasma removed. They don't talk much about skin removal or dermatochalasis, but you can put that into their mind that along with this, we can also remove extra skin. But these are two patients where limited surgical excisions have been done. And this is the second patient where 2 sessions of RF excision has been done. Now, limited excision is very simple. I don't need to share the video here. You just remove that small strip of spindle of skin along with the xanthelasma tissue and then suture it back. A very important thing is to undermine the surrounding area, because you don't want tension in this area, and don't go beyond the punctum or beyond the medial canthus, because that is an area where webbing can happen more often. In the suture bites, avoid taking orbicularis bites. It should be just skin, so that because orbicularis, when it contracts, it can splay the wound and it can also lead to webbing. Now, one interesting thing that we found when we are excising these xanthelasmas, which appear skin deep, you see a xanthelasma is also seen within the orbicularis. So I believe that there are deeper components as well where the orbicularis also gets involved, and you need to excise that as well while removing. So you need to have a very clear sort of visualization, and you need to remove this, otherwise early recurrence is very common. Now, some patients who are very cosmetically inclined can undergo an extended blepharoplasty along with xanthelasma removal in the same sitting. So mostly you will see that these xanthelasma lesions are above the eyelid crease. So sometimes you have to modify your medial end of the incision. Sometimes it might end up going above the eyelid fold. That doesn't matter. Initially, I used to get scared to go above the eyelid fold. As long as you get the fold in place and it's symmetrical, it heals very well and it's hardly visible. The main thing is that you should not have too much traction on these. Now, what is to be sort of taken back from this talk is that in surgical excision, hypertrophic scars are very common in the medial canthal area. So see here, if you go medial to the medial canthus, you're going to end up with a scar because there's a contraction or pull from the nasal region. It is not ideal for lesions over the canthal areas for the nose or for the lower eyelid where there is not too much skin to excise, and always avoid it for diffuse lesions because you can never get a clear margin. Recurrence is going to happen very faster. Radiofrequency ablation, on the other hand, I've started doing more and more. It's basically nothing but your Elman or a radiofrequency cautery, but you need to have a micro insulated needle tip so that the delivery of power is very focused. It's a very fine tip. You get it otherwise as well is along with your other radiofrequency cauteries. It can penetrate the skin easily without having to use a needle. And it is very controlled energy. The energy power settings have to be very low. You can see that it is just being put just beneath the dermis, and small boluses of energy are being put. Now, this again acts on the action that phagocytosis is happening here, and it takes an sort of engulfs the foam histiocytes which are present in that region. Usually, this is done under local anesthesia. You have to apply a little bit of prilocaine before infiltrating local anesthesia, but I give around 0.5 cc of a nerve block so that the whole area becomes numb. And first sitting should always be more gradual, more cautious, because you want to avoid hyperpigmentation. Depending on the response to the first sitting, I usually advise a couple of more sittings to the patient 6 weeks apart. If the patient is doing well, 3 sittings are more than enough for radiofrequency ablation. So for lower eyelid lesions which extend beyond the tear trough or sometimes which are amoeboid in nature, this works very well. Sometimes this works well also to downstage the lesion or downsize the lesions and make it amenable for surgery. Finally, radiofrequency ablation is a blind procedure because you don't know the depth you're entering. The depth is going to be variable in each pass that you do. More than the depth, Indian skin is more prone to post-inflammatory hyperpigmentation. So you have to counsel them about that it might take 2 to 3 weeks to go away. And sometimes thermal abrasion and excessive cautery can cause a fistula-like thing at the lower eyelid because the skin is very thin. So you need to be careful. That's why I always say that first session, always go easy, see how the skin reacts, and then go ahead and do your subsequent sessions. These are some patients who have done very well. You can see without surgery, just with radiofrequency ablation, the upper eyelid lesion has completely regressed. Sometimes they might do well, and sometimes that is what makes the patient happy. They just like to see some improvement, and psychologically they are happy, and they keep coming back to you. So here you see the lower eyelid, this has been excised, but these areas which you see have been radiofrequency ablation has been done. Here there is a little bit of scar which is because of the excision. Now, similar, this is the same patient with the eyes closed. You can see this is a combination of surgery and radiofrequency ablation. But then obviously you have to tell about the recurrence. I think 1 out of 5 patients in xanthelasma always recurs. Early recurrence is not very common, but you see recurrences around 6 to 12 months if they have to recur. Now, these are the patients who are very difficult to treat. Asymmetric lesions, you see this lesion is amenable to surgery or RF. This lesion is amoeboid. It has a different sort of depth here, a little bit of skip area here. So these can be treated with surgery, or they can be downgraded by radiofrequency ablation or CO2 lasers and then made amenable for surgery. So you need to mix and match. You also need to know that some xanthelasmas are incurable. You cannot go aggressively removing everything, or you might end up with a skin graft, which might not have as a good color match, and it might look worse than a xanthelasma. You can make them less obvious, or sometimes just raise your hands up and say that you should not do anything for this, or we can just reduce it in size. Last but not the least, sometimes patients don't know what it is. Sometimes the aesthetic physicians, we have MBBS doctors, anesthetists, we have a lot of quacks practicing aesthetic medicine who might do radiofrequency ablations, like this patient had undergone a lot of lasers, peels for this lesion. In the quest for cosmesis, sometimes you might forget that there's a pathology lying behind. This is a classic case of a xanthogranuloma, adult onset xanthogranuloma, which presents like a xanthelasma for a normal doctor. They might not have, but when it comes to you, you need to do a biopsy and treat it accordingly. Thank you. If there are any questions, I'm.
Thank you, Dr. Adit. Contrary to what you said, that it would be very brief, it was actually a very extensive lecture on a very small topic. So we got to learn a lot from that, actually. A lot of small tips for all of us. Dr. Aditi, any personal experience or anything you would like to add?
I think Sir summarized it quite well, that the risk of recurrence or the chance of recurrence has to be properly explained. So again, consent form for that. And they're quite the small lesions are quite gratifying to treat initially, but then when the patient comes back 6 months or a year later, the doc, these are back. So if you've explained that beforehand, how routinely would you advise lipid testing? I mean, because there's no frank correlation unless it's a young age, but patients do ask that. Is it because of cholesterol? So have you seen?
So mostly all my patients before surgery, I do advise lipid testing.
Dr. Ayushi?
Yeah. Is it true that patients who have deranged lipid profile have higher chances of recurrence? Do you explain that to them?
You see, it's not proven that patients who have a higher lipid profile will have a higher recurrence, because there are patients who have a higher lipid profile but don't have xanthelasmas. But as a physician, and if you want to be on a safe side, and if you're performing a surgery, especially in India, where the patient demands are different as compared to the West, or where you are currently, where they accept recurrence more gracefully, it is always better if the patient has a deranged lipid profile, you put it on them. Yeah, you have higher chances of recurrence. It doesn't harm your practice by telling them this one statement. So at least in private practice, you have to guard your fort very carefully. So, because the patient is directly coming back to you, it's not going to your fellow. Even if it goes to your fellow, it's going to come to you eventually. So, if they have a lipid profile derangement, you can tell them that your body is not breaking down lipids easily. So, there are chances of recurrence. In a normal case, it would be 1 out of 5. In your case, it might be 2 out of 5. So, I always try to put the blame on the patient if it's not harmful.
Thank you so much. That was wonderful. I had another question about the medial canthal scarring that you showed. It's so difficult to treat that.
Yeah.
So do you have a dictum for that? Like if the patient comes in early stage, you do non-surgical management and...
So the best way is to prevent it. And how I have had one patient who had a medial canthal scarring, and the best way is to notice it on table. When you're closing anything in the medial canthus area, you ask the patient to blink, because you hardly require any local anesthesia here. So the tissues are not very boggy. Hardly 1 cc local anesthesia is good enough for xanthelasma excision. So when you are closing the medial canthal area, even in a blepharoplasty, you will notice if you are creating a web. When you put the last bite in, you will, if there is excess traction, or if you have tugged at the orbicularis, when the patient blinks, you will notice a small band forming. As soon as I see that band, I revise all my sutures again and try to not have that band. If there could be a false band forming as well, where I have been stressed, where I've taken utmost caution to suture the medial canthus, but still there has been a band which I see, but it is sometimes because of tissue edema. But in xanthelasma, we don't use too much. But if you notice on, suppose, 1 week follow-up, that there is a small canthal scar, sometimes we notice that in DCR as well, right? DCR surgery, the superiormost stitch will cause a small crescentic band. I immediately give them a combination of 5-FU and steroid. And if you have access to CO2 laser, you should, after 2 or 3 weeks, immediately do CO2 laser to soften that scar, so that it doesn't progress to a frank sort of canthal webbing. But if it does, suppose if it's someone else's patient and comes to you, then it's one of the most difficult sort of things to treat. You do need to do sometimes Z-plasties or repositioning flaps to sort of take care of it. But I always hope that I don't end up with a medial canthal web.
Thank you so much. And one last question. How did you treat that amoeboid xanthelasma?
So that lady, we did RF ablation, and then she didn't turn back. So maybe she's happy. No news is good news. But asymmetric xanthelasmas, and when they have amoeboid lesions, that means it's growing. So that is a indicator that the chances of recurrence are high. It's on anecdotal, but when it's a localized nodular thing, that means the growth is almost complete. It is well defined and delineated. But when it is in a different shape, so either sometimes these patients don't reveal what they've done in the past. They're like, oh, karaya tha kuch. They don't know the history of what has been done. So either it is treated before or it is growing. So in those patients, I usually never do surgery because in India, surgery means perfection. The patients have unrealistic expectations from any surgery that you perform.
That's true. Thank you so much. Dr. Sumay, do you have any comments or questions?
Yeah, Dr. Adit, that was a wonderful talk, and I think as Rutuja put it, you have made such an eloquent explanation of such a simple topic. But I have a question regarding what you mentioned of the Q switch and other energy-based devices. So, since you have also been in practice for a decade now, you've seen your xanthelasmas come back to you, and have you seen that these recurrences post, or I don't know if you'd call them recurrences, when you kind of subtly try to shrink them down in size, are they tougher to treat later, or are
Yeah.
these surgeries more challenging?
So surgeries are more challenging when they come to you after a peel, after a TCA peel, because it usually the mechanism is that it ablates that skin, right? It burns that skin off. Peel is nothing but superficial chelation or ablation of the skin. So they end up with variable pigmentation, fibrosis, and more vascularity than a virgin xanthelasma. So they are certainly more difficult to treat because they are at variable depths. So you can't get a clean surgical cut. You have to sort of do variable excision. Sometimes along with surgical excision, I also do, like how people retina specialists do a barrage laser at the borders. I do a barrage laser on the borders of the xanthelasma margin, surgical margin, so that if I have left something behind, it gets taken care of by the phagocytes. It's just uh, like a practical tip, but that is what I do. But if it has to recur, it will recur.
Thank you.
And yeah, and you had shown one of those placoid kind of ones which were treated earlier, and big ones that was in a female. So suppose it's in a male, and you don't have the freedom to do a blepharoplasty because it might increase their tarsal show. What do you recommend for that? Because it's thick and you have to excise it.
So there are cases where people have done segmental excision. So what they do is they divide the xanthelasma into 2, 3 sort of quadrants. Wherever there is the most forgiving skin present, they excise that area first, remove it, wait for a couple of months, 3 months, 6 months to heal, then go for the next area and then sort of close that. So segmental excision is one thing which has been described. The other option is then if the patient is very keen and accepts a skin graft in the lower eyelid, especially, you can go ahead, remove and put a skin graft there. Or in the upper eyelid, you can go ahead and do a blepharoplasty.
Okay, very nice tip. Thank you. So, if anybody has any final comments. Okay, I think that was a wonderful webinar, if I say so myself, because I organized it, but not just because of that. I think the speakers were of very high quality. The team also was very good. Ayushi, Sumer, Aditi, a wonderful team also guiding the discussion. And I quite enjoyed it myself. Thank you, Dr. Prerna, also for giving such it's when people who have been through starting phase, in between, and then seen complications, that's when you get to learn the most. So I think we had the best set of speakers for this as well. So on behalf of YOSI, I'd like to thank everybody for being a part of this. And I think it will be a great resource which will be viewed several times going forward on YouTube also. And if y'all are willing to come for YOSI, if you could come and guide them further, we would love to have you at YOSICon also. It's July 10th to 12th at Pullman in New Delhi. And thank you, everyone. Great session. And I think we can close. Thank you,
Thank you.
Manju.
Thank you. Bye.
Thank you, team. Thank you, Rituja, for including us in this
Yes.
wonderful session.
Thank you.
And
Thoroughly enjoyed.
All right. Bye.
Bye. See you.
Manjula ji.